give me this opportunity. Sorry. Thank you to give me this opportunity. I am going today to give a quick talk about the main condition for the forefoot in the FRCS. Sorry. So the main content is the Hallux Valgus and Hallux rigidus. These are the main topics for the forefoot conditions. And then we will touch quickly about the lesser toes deformities and the motor neuron. So before I get started, I like the 5Ds approach to the to your answers. So it's quite important that you don't only have a knowledge for the part 2, but also the structure. So the 5D structure, 5D system make you quite organized in your answer. So starting first with describe the picture, the X-ray, the MRI, the microscopic picture, whatever. And then straight away, go to the diagnosis. Say your diagnosis, and also if there's any concern, say it straight away. Once you say that, once you say the diagnosis or your concerns, the examiner will calm down a bit. The third one is discuss. Discuss here means give the history, clinical examination, investigation. And the investigation, it can be laboratory or radiological or whatever. And then decide. Decide means the treatment. And again, your treatment needs to be organized. Start with the conservative. Never forget about the conservative treatment, okay? Then the operative management. And last thing is to give, if you come to this level, then you are scoring 7 or 8. Then you enhance your answer with a diagram, with a picture, or a detective mean here, an evidence or discussion point. A controversy. I got this this system from Rishi, and it worked well for me. So starting with the Hallux Valgus. So a picture like this, you're going to start describing the picture. This is there is a bilateral Hallux Valgus deformity. There is a prominent bunion. The deformity was on the right side. There is a pronation deformity of the big toe. There are lesser toe deformities. All right, this is the description. This is a bilateral Hallux Valgus, was on the right side. Then history. The history you divided into the history of present complaint and the risk factor history. So the history of present complaint is whether it is pain or deformity. You know, your history will give you hints for your treatment. So if it is only deformity, then you may just treat it conservatively and discuss it with the patient. If there's pain, you may think about the operative management. And here there's a question: what are the causes of the pain? The pain can be either intrinsic or extrinsic to the joint. So if it is intrinsic, this can be due to the arthritis, incongruency of the joint, or extrinsic, such as that with the Hallux Valgus, it can lead to dysfunction of the first ray and metatarsalgia. Okay, so the load goes off from the first ray to the lesser toes, and this gives pain, callosities, metatarsal head callosities, and metatarsalgia symptoms. So this is the history. History of present complaint is either pain and deformity, and then ask about the risk factor history, which can be like family history, sure wear, whatever. Okay. Examination in foot in general, try to make it quite organized. So start with the forefoot, midfoot, hindfoot, and general. So forefoot, you're gonna examine the big toe itself, whether it is whether it is the deformity is flexible. Examine the lesser toes, whether the deformity of the forefoot. Examine for the midfoot by examining for any associated flat foot deformity. First, TMT joint hypermobility. And examine the hind foot, as we said, if there's a flat foot deformity, there will be hindfoot valgus. And always in the feet, examine for the general examination, which here is hyperlaxity. So if you have any feet in the exam, think about general examination. Don't forget it. So, for example, if you have rheumatoid picture of foot, think about the general manifestation of the rheumatoid arthritis. Examine the hands. If you have pes cavus, examine the spine, examine the hands. If you have flat foot deformity, examine generally for hyperlaxity. So general examination in the feet is quite important. Okay. Next, after you do the examination, you're gonna ask for an X-ray. An X-ray in foot in general, ask for weight-bearing X-ray. So here here is the sorry. So here's the X-ray. So I'll comment on the angles. You don't have to mention numbers in the exam. So straight away, just say increased hallux valgus angle, increased intermetatarsal angle. All right. Don't confuse yourself with numbers. Okay. And then mention about the joint itself, whether there's any arthritis, any degenerative changes, if there's incongruency. Comment about that the sesamoid is uncovered. By the way, the sesamoid doesn't subluxate, it doesn't dislocate. It's actually uncovered by the first metatarsal head. Okay, so the sesamoid stays in place. The thing that moved is the first metatarsal head. And lastly, one of the angle is the DMMA. All right. So the DMMA is distal metatarsal articular angle, which essentially, if you drew a line at the if you drew a line that is coincide the axis of the first metatarsal and drew a line that connects the equator of the articular surface, this line drew another perpendicular line to it, and the angle in between these two lines, okay, it should be less than 10, okay. If it is more than 10, then the DMAA is increased, and the importance of it, if you have increased DMAA angle, this means that you have a congruent joint. So any distal soft tissue procedure is contraindicated. And the reason is, if you do a distal soft tissue release, this will lead to incongruency of the joint. The last thing is the decision or the management. Never forget the conservative treatment. So conservative treatment start with changing the shoe wear, wide forefoot box, padding, tapping, whatever, okay? Then the operative management, okay? The operative management, there are many procedures described in books, but here in the UK, the most common is chevron osteotomy or scarf osteotomy, all right? You have to know how to draw. Choose one of them and make sure that you know it in out, because you're gonna be asked about it, okay? So for most of the cases, chevron osteotomy or scarf osteotomy, we'll come back to it. Okay, for the Hello? Uh, okay. For the hypermobile joint, first it will be first TMT fusion. For any evidence for advanced arthritis or rheumatoid arthritis or neuromuscular disease, it's the first MTP fusion. Okay. So when you asked about for example, the scarf osteotomy, if you're gonna say scarf osteotomy, so say the full line, say I'm gonna do a scarf osteotomy, plus or minus Aiken osteotomy, plus or minus lateral release, and we'll discuss a bit about these. So the scarf osteotomy is Z-shape osteotomy. The horizontal component is parallel to the ground. The distal component is dorsal. Just to remember that distal is dorsal to D for D, okay? And the proximal is plantar, okay? It's important that you know how to draw it. So if you choose to go for a scarf osteotomy, don't just say, I'm gonna do a scarf osteotomy. No, say, I'm gonna do scarf osteotomy, plus or minus Aiken osteotomy, plus or minus distal soft tissue release. How are you gonna do this? I'm gonna, the patient is consented and marked. Then I'm gonna do the medial approach, protecting the dorsal medial nerve. I'm gonna do the scarf osteotomy in this way, blah, 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 blah. So, I mean, try to talk in the exam. Don't just say, I'm gonna do scarf osteotomy. Try keeping talking, okay? The lateral release or the modified McBride, essentially you release the abductor tendon, the abductor hallucis tendon, and also the metatarsal-sesamoid suspensory ligament, all right? It's called modified because the original McBride, they used to excise the fibular sesamoid. But the problem with this is that it can overcorrect the deformity to Hallux Valgus, okay? And it can be done through the same approach. If you are doing scarf osteotomy, you can go all the way to the lateral aspect of the first metatarsal and release these structures, or it can be done through a separate approach, small separate approach, just lateral to the first MTP joint. The second topic is hallux rigidus, and again, you're gonna, for example, given an X-ray like this, or given a picture or whatever, then it's describe the X-ray. So say there is advanced arthritis of the first TMT joint, the first MTP joint. There's slight, for example, Hallux Valgus deformity. This is a Hallux rigidus. This is a picture of Hallux rigidus. I'm going to take a history in the form of pain and asking for pain and stiffness. The pain usually in arthritis, sometimes it's activity related, whether it wakes up the patient at night. And also in hallux rigidus, ask about whether see whether the pain is at the end of the range of movement or through the range of movement. If it is at the end of the range of movement, it may be due to the prominent osteophyte. If it is throughout the range of movement, then it may mean that this is advanced arthritis of the whole joint. The same thing happens in the ankle. Ask the same question in the ankle and in the elbow. So if the pain is in range of movement, then you just possibly just end up with thylectomy rather than the whole joint fusion. Examination, again, go systematic. Examine the forefoot, midfoot, hindfoot, if you can, and the calf. So the forefoot, examine the joint itself, the mobility of the joint, examine the range of movement, examine the lesser toes, examine the midfoot for first TMT hypermobility, and this sometimes is a cause for this hallux rigidus. Examine for the tightness of the calf as well. Sometimes when you have a tight calf, you have short second rocker of the foot, so you load the forefoot quite a lot. That's why you get this condition. Investigation again, get a weight-bearing X-ray. Management, again, don't forget the conservative treatment, Morton shoe modification, insoles like Morton extension, but don't forget about it. Then operative management. The operative management will depend on the severity of your of the condition. If it is mild or moderate, then you do a chylectomy. So essentially, you debride the dorsal osteophyte, and you debride the dorsal osteophyte with about 30% of the joint, the dorsal aspect of the joint. So if you ask how you're gonna do it, say dorsomedial approach. I'm gonna protect the dorsomedial cutaneous nerve, and then I'm gonna debride the osteophyte and about 30% of the dorsal aspect of the joint. For the severe disease, you have two options. One is joint arthrodesis, which is the gold standard, or MTP joint replacement. It's usually the arthrodesis, but still you have to give the options for the patient. The same thing in the ankle arthritis, the end stage. You have to give the options for the patients. Usually, you're going to say that you are more familiar with the arthrodesis, but still you have to give the patient the other option. And in this case, you may refer the patient for someone who does the arthroplasty. So whether it is joint preserving or joint sacrificing, we have the arthrodesis is still the gold standard. What is the problem with the arthrodesis in general? The problem is the non-union, okay? And the other problem is that it is joint sacrificing, so the loads will go to nearby joints, causing premature arthritis. This is the same answer for any fusion in the body. If you do ankle fusion, what's the problem with ankle fusion? Is one is the risk of non-union, and stress will be transferred to other joints. How to do a fusion? It's any fusion. Talk about these steps. One is your approach, okay? Then preparing the joint, then restoring the alignment, and then fixation. So in this case, you're gonna say, you're gonna do a dorsomedial approach, protecting the dorsomedial nerve. Then number two is preparing the joint, removing all the articular surface, penetrating all the subchondral bone, and then positioning the joint. So in the hallux valgus, you have to know about the position of the joint before the fusion. So essentially 10 degrees of valgus, about 15 degrees dorsiflexion from the ground. And last thing is fixation, either with a screw, with a plate, with the staples, whatever, okay? But it's the same thing applies to any joint arthrodesis. How are you gonna do ankle arthrodesis? Well, I'm gonna do anterior approach. I'm gonna do the preparation of the joint, removing all the cartilage and subchondral bone penetration. I'm gonna do restore the alignment of the joint. I'm gonna do, which is neutral, 5 degrees of valgus, 5 degrees of external rotation, and then fixation, screws, plates, whatever. Okay. And the last thing is the MTP joint replacement. It's quite a recent trend. The short and mid-term results are improving. Quickly talking about the lateral toes deformity, you have three problems, which are the hammer toe, claw toe, and mallet toe. Have a quick look on them. The mallet toe is only the DIP which is affected. The claw toe, the PIP is the one which is affected. The claw toe is that all the joints are affected, including the hyperextension. What is the treatment? Again, this is mainly for the claw toe and the hammer toe. So the management, again, don't forget about the conservative treatment. Always mention it, which can be shoe modification, shoe wear modifications, padding, tapping, whatever. And then the operative management, it will depend whether it is a flexible deformity or fixed deformity. If it is flexible deformity, you can do soft tissue procedure, which is flexor to extensor tendon transfer. However, here in the UK, usually they do bony procedures, even if it is flexible. It is written in the book that flexor to extensor tendon transfer, but in most of the cases I've seen here, they just do PIP arthroplasty or PIP fusion, which is so PIP fusion, extensor plus or minus extensor tendon lengthening, MTP joint release, and sometimes the adder wheel osteotomy. This is in most of the cases. I haven't seen flexor to extensor tendon transfer except in one time, and it's not very common here in the UK. Lastly is the interdigit, the motor neuroma. You're going to be asked, it's usually in the third space. Why it is in the third space? Because here is the joining between the medial and lateral plantar nerves. So it's probably more sort of traction neuritis in this third web space nerve. The symptoms is forefoot pain, neuritic pain, pins, needles, tingling, all of that. Examination will be some tenderness in the intertarsal space, Mulder-Click test. And the management, again, of course, you can ask about the ultrasound scan, and then the conservative treatment, including injection. Sorry, I didn't mention the injection in the hallux rigidus, in the hallux rigidus problems. But again, conservative treatment, don't forget the injection. And the surgery can be either dorsal approach or plantar approach. Usually the plantar approach for the recurrent neuromas, where it gives direct access to the nerve, but the problem is that the scars on the plantar aspect of the foot is quite not very comfortable. The dorsal approach, you divide in the intertarsal space, identify the transverse intertarsal ligament and release it, and then identify the nerve, release around the nerve, and make sure you cut about 2 centimeter segment of the nerve to prevent the recurrence, and warn the patient that they may have, because you are excising the nerve, you may end up with some loss of sensation in this too. And thank you.
Thank you very much, Abdullah. So really Excellent lecture and presentation for a very common topics, either in the Viva or in the clinical. So Hallux Valgus, Hallux rigidus are 40% or maybe 50% of you would be asked one of these in the clinical or in the Viva. So it's very, very common topic. Thank you, Abdullah. So we will start now answering the questions. Please write down any questions you want to ask. Okay, so I will ask you questions, Abdullah. Do you do an MRI scan for interdigital neuroma? Or it's just a clinical diagnosis?
It's more like a clinical diagnosis. We usually do ultrasound. The ultrasound, the benefit of the ultrasound is that you can add ultrasound plus or minus injection. And in the neuroma as well, you need to, it can, if you have like symptoms like forefoot or motor neuroma, sometimes you confuse it with the metatarsalgia, for example. The patient has pain around the lesser toes area, and the problem can be due to, for example, loading of the forefoot. For example, if the patient have tight calf, okay, if you imagine that during the walking, the gait cycle, you know, you lost the rocker, the second rocker of the foot. This leads, like, if you're hammering the forefoot every time you walk.
Yes.
So it's quite important to exclude the other causes, for example, or the other causes of metatarsalgia, such as, for example, as we mentioned here, the first ray problems. If the first ray is shortened or has a hallux valgus, this leads to dysfunction and increase the load on the lesser metatarsals. So it's essentially clinical examination to find out what is the cause of this metatarsalgia. If you find that there is some plantar keratosis under the tarsal head, is most likely that this is not motor neuroma. It's due to something else, as I mentioned now. But then you can request an ultrasound or an MRI. But the good thing with the ultrasound is that the option of doing the injection in the same go.
Okay, so we have Matwali. How to avoid troughing in scarf osteotomy?
Good question. It's so the troughing, you can expect the troughing if, for example, essentially in the osteoporotic bone. Okay.
Yeah.
So what happens is, so the two ends of the bone, when you shift the bone in the scarf osteotomy, they just interdigitate with each other. So it's essentially the cuts. The cuts are important in the cuts are important in the scarf osteotomy to be parallel.
Yeah.
And also you have to expect in the osteoporotic bone that this can happen. If this happens, it's quite sometimes difficult to sort it out, but if you put the screws, make sure that you put screws rather than compression screws.
Okay, so in case of mid-foot arthritis and hallux rigidus, so what's that like? What's the plan for management here? So we'll start proximally to distal or distal to proximal, or depends on the patient symptoms. So what do you think, Abdullah?
I'm not 100% sure, but I would consider I would discuss with the patient and find where's the problem and take it from there.
Okay.
I'm not really sure. And also we can use the injection as more diagnostic. Where is the problem?
Okay, so we maybe inject here and we'll see. Okay. And for overriding second toe plus Hallux Valgus, so what's the treatment?
It's quite the overriding second toe is quite difficult problem. You have to discuss this with the patient because it may need some sort of bony and soft tissue, and the problem is quite the soft tissue of the second toe is really flimsy. It's very, very small. So I've asked some consultants about it, and they told me is quite difficult to treat, and this has to be quite clear to the patient.
So what's your answer in the exam, Abdullah? So what you say in the exam? If you have a case like that,
so
you should discuss it with a foot and ankle surgeon, or what you think?
Yeah, so it's more like a soft tissue balancing. So the which is the lateral collateral ligament, lateral collateral ligament reconstruction of the second toe, plus or minus. If there's a sagittal deformity, then you do like PIP arthrodesis.
Okay, I think arthrodesis is the wise answer here.
The arthrodesis will sort out the sagittal deformity, but it may not sort the
deviation. Okay.
But even with the reconstruction of the collateral ligament, is quite the results are not the best. Still not the best.
Okay, that was the last question. Thank you very much, Abdullah. So we'll stop recording now and we'll start Viva. We have 4 candidates raised their hand for Viva. So we'll start now.